pharmacies and community PCPs. So we're out of the hospital. We're just out in the regular ambulatory world. I can tell you a little bit about what literature reveals, a little bit about experiences and challenges, and then I'm going to ask you guys, and that's what Megan passed out for us. I'm going to give you a little time to complete this after I kind of go through a few slides here, because I want to do a little data collection, and this is going to help us with our project with the California Department of Public Health. Okay. So first I want to show you, and these slides are not in the slides that are going to be posted. I took these from our work. I didn't think you might not know what a protocol looked like. What is this collaborative practice protocol we're talking about? And the key points to me are, okay, who's the patient population? Right? And hopefully I took all the names out here. It's, in this particular case, we're looking at, these are patients who, they're receiving continuous medical care, and we're looking at hypertension management, okay? We have inclusion criteria, there is exclusion criteria. It's very specific. And then we have, all right, pharmacist privileges. What can the pharmacist do? So we have to do that, but obviously it's very, very detailed. Review the record, identify risk factors, review blood pressures. We have specific goals that we're looking for. Evaluate the medication therapy and their adherence to therapy, and identify problems, medication-related problems, etc. Assess ASCVD risks, etc. Review and implement lifestyle modifications. Down here, adjust medication therapy if indicated to meet treatment goals. Right? So now this is the key difference, is that pharmacist right there can change the therapy.
And according to those risk calculators, you can add an aspirin and you can add a statin. Is that what I saw on that last slide?
Back here. Yes.
Number 7, number...
Yeah.
Yes.
Yeah,
Okay.
6.
Yes. Right.
6A and B. That's
Yeah.
kind of big right there, 6A and B.
So these are very specific, but now to think about it, this could be a different protocol with a different group somewhere else.
Yeah.
They're all different. Just because we say there's a collaborative practice protocol, it depends on, and don't take a picture of this, Patty. This is confidential. Thank you. No,
Just for my own edification.
That's why I did.
I'm so
That's
happy
why
to
I
see
did not
this.
do that. Thank you. So sorry.
So Megan, just note that we can't post that slide.
I've already talked to her.
Okay.
Yeah. Okay. But I want you to look at the detail that's in here. They're also ordering laboratory tests. This is a lot of things that the pharmacist is doing that a community pharmacist doesn't normally do. And the idea of this is we want to put this type of protocol in community pharmacy with PCPs that are in the community. Then down here, basically, there is a list of drugs, specific drugs. Okay, so that's my point. That specific list of drugs, it didn't include diabetes drugs. So if they find something of that, they can't change that, but they can change hypertension. And so just want to give you a flavor of that. Keep that in your mind.
So is that an existing collaborative practice order that
Yes.
you're working on?
Yes.
Is it in Southern California, Northern California,
Southern
California, United
California.
States?
Southern
England?
California. Southern California. As I said, we have a group that we have clients with, so I can't say a lot. No. Okay. So in the literature, I got one slide on this because there's not much. All right? There are a limited number of studies that are looking at community pharmacies that are having some sort of collaborative practice. And even those you can find, the implementation, the description of the implementation, very limited. And obviously, kind of what we're focused on now is we think this is going to work. How do we implement it? What are going to be barriers and facilitators? Some of the elements to think about are patient population, and we've been talking about different patient populations, hypertension only or broadly, all the things, hypertension, diabetes, or COPD, or just anything. What do we bite off here? That's going to drive the scope of the agreement and the protocol. Now, if you think about this, a hypertension-specific protocol may be easier, and probably so, to start with, but then you are focused on the part where we just have, well, what about diabetes? People don't just come with hypertension normally. Pharmacist credentials. Steve touched on this already. Training, special training, is this something for every pharmacist? Are there special credentials? Do they need board certification? Lots of questions swirling around about that. Integration between the organizations, like that slide I showed you earlier with all the lines, et cetera. To make it happen, you gotta have all those lines because we're not connected. That's the whole point. We're trying to connect PCPs, and these are different groups of PCPs and a community pharmacy, and trying to put all that together. Certainly the IT itself, access to the electronic medical record of those PCPs. First in the community pharmacy, basically the PIH hospital is giving access to Rouse, but that's one hospital. That's not multiple different PCPs.
And that was one hospital that was encouraged by one health plan medical
Yes.
director by looking, being very specific and engaged. So how do you upscale that?
And that's absolutely true, and we can't forget what Jeff did. He looked around at, different hospitals and things that needed help. Needed help. Where can we actually implement something to help from the data that you are already seeing?
Or some other, yeah.
Or that they had enlightened leadership that would be willing to do something innovative.
Not as much as that. I mean, it was more like, well, that's true.
Yeah. So the processes obviously have to be worked out, and communication. I don't need to even say that, but communication amongst all the players is going to be key. Yes?
I kind of see all the key elements. I actually think the biggest challenge is probably getting the physician buy-in to understand the scope of practice from the physician. Because when we implemented our integrated with our pharmacists, and we had been doing anti-coag for years, and they're like,
Right.
they trust us with everything. But it was actually really difficult to get those physicians that we worked with for many years
Mhm.
to all of a sudden say, okay, take my patient,
And to understand that in a different way of what you can do.
Right.
Right,
Yeah.
definitely.
So that kind of brings up my question. Who would you expect to be signing these collaborative agreements? Okay, so is it between an individual pharmacist and an individual physician? That doesn't seem quite right. Or is it between a pharmacy or a chain and a group of physicians? How do you see that happening?
The way and I'm interested in others talking too, the way we see it at this moment and have had success is actually through the organizations. It's not because those, not anymore, you don't work for yourself anymore. Pharmacists don't and physicians don't, they're in the medical group. So it's a medical group and a chain, or a medical group and an individual pharmacy. Yeah, it's that
Right.
collaboration.
So then the medical group that's signing on behalf of their physicians
Yes.
is going to have to make sure that the physicians don't revolt on them.
There's a lot of education that has to go into it, and the physicians have to buy in to some degree. And their medical management has to make that happen on the medical side. Do you want to comment?
Well, I was just gonna say, and then the next step is the IPA organization, where the medical director can't really speak
Mhm.
for each of the individual physicians. I mean, we had sort of a failed implementation at an IPA because that medical director champion, really, his role was to go out and make sure that his docs bought in, but there wasn't enough of that, I think. And we did want the CPA with each individual office, and
Yeah, in an IPA situation, I think legally, the IPA cannot,
Yeah.
the very limited range of things that they can
Mhm.
sign, and I don't think that includes this, and
I
so,
think it could work in a,
It-
if
it
you
can
had that strong
definitely work
physician
in a
champion
group
that was out there
practice.
promoting
an
it.
IPA could perhaps promote it and get signatures from the individual
Mhm.
physicians.
Exactly.
They won't be 100% successful. And then you got a problem where some of the doctors signed on and others
Right.
didn't.
Well, then that's when we have to target the right
Yeah.
patients for that. Because in the end, it is, I was saying, we're going to organizations, you have But in the end, it is between the pharmacist and that physician making that agreement, regardless who signs it.
Well, you just end up with 2 protocols, right?
Yes.
So one, they can make changes on their own without nagging the doc. And then if they don't have this EPA, they can suggest changes.
See, you have a comment?
Just, so I think everything you said so far, I agree with. Then the barbershop project was actually pretty easy. They had mostly individuals, DPAs with physicians. And when you have the author of the Bible for hypertension, who's
That helps.
promoting the CPA,
Yeah.
authored by him, it was an easy sell.
Yeah.
So I think it was already said, when you have the right physician champion, it is not so difficult.
He's promoting the
yeah.
collaborative practice agreement, not the CPA, because if we
Well, that is
work in
CPA.
acronyms,
Oh,
Yeah,
no.
sorry.
then we'll never
Yeah.
bring the physicians
Collaborative
along.
practice
Yes,
agreement.
yes, yes.
Yeah,
Okay,
so-
sorry about that.
So
Yes.
having a great physician champion is the key, absolutely.
Yeah.
And in fact, it was Jan and Steve and Rebecca Cupp, who's now the head of pharmacy for Kaiser, who convinced our San Diego group and our previous co-chair there, who's now with Blue Shield, to review the data and actually take it up and do something about it. One of the great skeptics was Dr. Scott Flynn, who took it to his medical group tentatively and found that the performance in the physician champion pharmacy pairings was so much greater that he converted the whole medical group. And now he's working to do it through a large health plan.
Much larger health plan, yeah.
I'll just add one other little comment. I think when it comes, there is a collaborative practice agreement and a protocol.
Yeah, I
And
was
they are
going to say
distinctly
that,
different,
yes.
because collaborative
Yes.
practice agreement gives you permission to do a variety of things. A protocol is more scripted.
The protocol is what you saw.
Right. So
Yes.
I think what's important
That's-
is you want to try to find that line between the two, because you don't want to be so cookbook that your pharmacists are stuck doing things one way that, gee, next month a big study comes out and you really should be doing that, but you're still doing it.
Well, my question is the protocol like an amendment to the collaborative practice agreement? In other words, they're not, they are linked, I think.
They are, correct.
And so you could sign a collaborative practice agreement and you could specify that this covers these protocols with this
Yes.
protocol, but not that.
Right.
Yeah, it could be as loose as referring to the current guideline.
Yeah.
It's not, it doesn't have to be so prescriptive, you're right,
Yeah.
I agree. But I'm saying, as a physician, I think you want some reassurance that there's a standard process, that there's some kind of QA that makes you feel safe, that your patients are being managed well, that they're managed safely. So there's a fine line there. I think what you have is pretty detailed and almost a little bit too prescriptive. I would try to back it off and talk more about drug classes instead of drugs, and try to open it up so you don't have to itemize.
We do have some others that are just classes,
Okay.
and they're multiple classes. That was just an example of one. So, okay, so I'm going to focus you. I need to focus you on this piece of paper. The California Department of Public Health thinks I'm going to collect this piece of paper. I'd like you to put your thoughts, just very briefly, take 3 or 4 minutes. Tell me basically your experience here, and just the things we're thinking about. Other things you're thinking about that are barriers or facilitators, actually, to being able to have a collaborative practice agreement and various protocols, whatever those
I
may
need one
be,
more of those.
between PCPs and community pharmacists. I'm sorry, here. Couldn't give it mine. I'm gonna give you 4 minutes, and then we'll see if there are any big ahas that we haven't already talked about. So I see a number of you are finishing up. Thank you very much. Let's just start at the top here. Barriers to creating. We've talked about a lot of barriers so far. Anybody have come up with any barriers to either creating it, because it's going to be three different kind of phases. Creating, implementing, I think we've talked about a number of those. Any barriers that you thought of that we haven't already mentioned?
So I know some of the community pharmacists that I talk to, a barrier would be not having time to implement this comprehensive medication management process into their workflow, and then also having reservations about, assuming that liability for comprehensive medication management.
Okay. Time of the pharmacist itself and liability that comes with that, which is a very different thing than we are used to in a community pharmacy.
I think a barrier to creating guidelines is, a barrier to creating protocols is when the guidelines are controversial or not accepted
Yes.
uniformly, and that's kind of a problem right now with this.
That's a good point, yes, okay. Yeah, the guidelines themselves are controversial, so how do you agree?
But are they controversial other than that, what level to shoot for? Because there is certainly a level of, for instance, hypertension control that we can all agree is necessary.
Oh, no, that's not true. Everybody agrees that hypertension control is necessary. What they don't agree on is what the level of control is.
But I think everybody can agree that, so a very high level, for instance, least
Yeah,
common
I
denominator.
think you're right, that there's a way to find the least common denominator and put it in your protocol, but then you'll get people that are saying, that's really not good enough.
But it's
yeah,
just-
but
it's
it-
a
but-
start
but-
somewhere.
But it is
So we
something,
could
yeah.
go with just like the
Yeah.
NCQA, which is what we've always done in the Right Care Initiative, just stick with
Yeah,
whatever
yeah.
NCQA.
But, it would be better if there was 100% consensus.
Okay, well, that's another thing we can
I
think
think
about.
avoiding controversial areas, because the whole study can fall on everybody arguing about one controversial area, and if you
And
can,
it can be a really small point.
yes, if you can
need
keep
to
that out
clearly-
of.
Yes, okay, we need to clearly define non-controversial area of medicine. Good luck finding that.
A
but
good
yeah,
starting
I know.
place is probably
Yeah,
hypertension.
It's clearer than
It's
if,
as good as
we
you
have
can
some
do.
other things in diabetes and it gets,
It gets worse after that.
murkier there, so,
Yeah.
how about facilitators? I know our time is very limited, but I would like to, facilitators, what would help make this happen?
I think if you could sell it on making life easier for physicians, anything that makes life easier for people sells
Mhm.
things.
I
Okay,
think you can also get like a specialist champion, so if you're just trying to have, sell this to the PCP, but if you can get a cardiologist or a cardiology group to really support you and back
Right.
you, then I think that would help.
kind of going the
Also
Ron
influence.
Victor route of having that level of
It's really important.
champion.
I was just saying, in a broad sense, it's gotta be someone besides the community pharmacist that's trying to sell it. We really need that support, whether it's from that cardiologist or the plan, the leader of the plan, saying
Right.
this program is to help you to be more efficient and
Mhm.
provide better care to your patients.
Okay. What's it? Yes?
From an IPA group setting,
Uh-huh.
and to incentivize our providers, you really need to create a model where you incentivize our providers linked with those measures that you're accountable for, like SNAP
Mhm.
measures. And so if there's no incentives, there's nothing that kind of draws their attention.
Right, it's gotta be something that's linked to them, it's helping them specifically, and their incentives need to be helped, right? It's not- Okay. Other thoughts on facilitators?
Really quickly, we're working with Inland Empire Health Plan on their pay-for-performance program,
Right.
targeting community pharmacists. What you just said is exactly what we talked about yesterday. The physicians have a very clear P4P program, very specific metrics. And the idea was, well, gee, half of them relate to medications. Why can't we have the pharmacists work together on that? So that's
Mhm.
really great.
Okay. Great. I'm going to have to cut us off now because we are at the end. I do appreciate your thoughts. I am going to collect those. All that information, thank you. The other thing is,
Yeah, please.
the continuing education, Patty asked me to tell you, you need to fill that out if you would like continuing education. There's evaluation there also.
If you
that needs
would
to be
please
completed.
fill out the continuing education, if we don't turn in enough, our provider won't do them in the future. So, you'll get the credit and so Are we missing some forms? Do we need some extra forms? Is that
Do
what's
everybody
happening?
have forms?
Oh, yeah, where are the funds? Names are.
Were they on the
I just keep
We
in
came
mind, why did I have one?
We came in early and did this.
Okay, I think I have one. Who needs them?
Thank you, I'll collect these, I want these.
Oh, okay, no, we got one. Okay. So when you're done with them, you give them to Megan.
If it opens up tomorrow.
Yeah. So I'll just announce the next meeting. While you're filling these out, and maybe when you're done filling them out, we can just get your thoughts on whether this is the right timing for the meeting. So we switched the timing at approximately the new year to have our lunch at 12 and then the program from 12:30 to 2:30. It seems to be working reasonably well. But some people are saying, well, could we just have lunch at 11:30 to 12, and the meeting from 12 to 2? So, you can email me your thoughts on that. The other thing is that we have a really fantastic program built out for the rest of the year. We'll be meeting right here on the third Thursday of every month. And next month, we will have the phenomenal cardiologist who sometimes co-chairs our meetings, Dr. Carol Watson from UCLA, and she'll be talking about diabetes and prevention in particular when somebody is diagnosed with pre-diabetes, how to prevent them from converting to diabetes, and some of the exciting things going on in the intersection between cardiology and diabetes. The following month, we will have Dr. Tony Kuo, who opened up the meeting, presenting along with, Tony Kuo is the LA Public Health Officer in charge of chronic disease, who is another member of our leadership group, pairing with one of our national members of our leadership group, Dr. Bob Kaplan, who was our initial NIH principal investigator on the Grand Opportunity Grant that helped us to implement on a regional level our San Diego pilot project. And he'll be talking about the very controversy that we were discussing, and that is what is the right level for hypertension and what goes into creating that guideline. He was the head of health services research for UCLA, and then went on to be the associate director of NIH, and then the chief science officer for the Agency for Healthcare Research and Quality. Now that he's come back to California, he's going to re-engage, and he'll be talking with us about what's coming up in those hypertension guidelines. Then in October, we'll be hearing from Dr. Norm Lepore, cardiologist from Cedars-Sinai and also at UCLA, and he'll be bringing some of his UCLA colleagues from Cedars-Sinai to talk about heart failure. And we will also have, somewhere in September, October, I'm not sure yet, the Heart Association is going to be talking about the actual fines that are being levied against hospitals in Los Angeles, and the variation there related to heart failure readmissions. Very, very big numbers, very compelling numbers for proactively managing care. Then in November, we will be hearing from Blue Shield and HealthNet about their progress on controlling hypertension, blood pressure, and cholesterol, meeting the Right Care Initiative targets generally, along with another surprise presenter. So that's what we have lined up for the year. We're going to take a break in December so everybody can have a winter holiday, and I look forward to your thoughts on programming for the new year, and any switch-ups that you're interested in, just email me. You all have my email. It's hattiehanley@Berkeley.edu. And all I can say is that every single one of you are critical in this endeavor to actually spread the best practices, because some of us who've been working on these together for, a decade or so, are thinking that perhaps if the voluntary method of getting the best practices to be taken up is not more effective over the next year or two, leveraging the legislature either at the state level or nationally will be on the planning boards. So anyway, stay tuned. Thank you for your participation, and please go out and encourage your families, your friends, your colleagues to do all they can do to know their numbers, control their numbers, de-stress, get their 7 to 8 hours of sleep a night, do a plant-centric diet. You know, we just had one of our members of our RightCare family stricken down this week from a heart attack and is no longer on the planet. So we got to take it seriously. It's not just something we do on paper, and we appreciate that those of us in the room kind of know that. So, but a lot of our friends and families have no idea how serious these issues are. So thank you for all that you're doing. Oh, and by the way, he was 56 years old. I'm sorry, I thought I had mentioned that, but
Really excited about that.
he's younger than I am.
Thanks, Steve. That was very good.
Thanks for coming. I didn't realize we had a keynote today. So I threw you under the bus. I said, "Oh, Jeff and Carol."
And we weren't even waiting for a payment.
Well, I'm glad you said, well, I just